subscribe now and press the bell icon. Never miss an update.
Welcome to Health Live at Seniors Today. We are here on a bright and some places a rainy Saturday, and we have moved from most of our doctors are from Mumbai or Delhi or sometimes in Pune. We haven't been to Bangalore too often, but today we are in Bangalore and we have with us Dr. Limesh M. Dr. Limesh is, I would like to introduce him. He's a consultant nephrologist and a transplant physician at the Mazumdar Shaw Medical Center at the Narayana Health City in Bengaluru. He has completed an MD in General Medicine from the JSS Medical Center in Mysore and a DNB in nephrology from NV Hospital in Chennai. He completed his fellowship in nephrology from the University of Ottawa in Canada, and he has been an associate professor of nephrology at the St. John's Medical College in Bengaluru. Welcome to Health Live at Seniors Today, Dr. Limesh. How are you?
I'm fine, sir. How are you doing?
Very well, thank you. You know, Doctor, we've had quite a few sessions, around 150 odd sessions over the last 3 years. And we've had nephrologists as well in the past, but we've never really looked at minutely the issue about electrolyte imbalance and low sodium lead delirium. And I must confess how I came to this topic. The other day I was looking at a topic which concerns illnesses that concern senior citizens, and I went to ChatGPT and I said, okay, what are the illnesses that concern senior citizens? Because sometimes we don't get it, and I looked up ChatGPT and I said, this is one of the and this is what it threw up, that this is one of the top illnesses affecting senior citizens. And off we went. We requested your team at Narayana Healthcare to suggest somebody, and they suggested your name, and here we are. So welcome once again to Health Live at Seniors Today. How are you?
I'm fine, sir. Thank you very much for giving me an opportunity to a whole new of experience to a new audience. So we usually used to address the doctors, our students, our medical fraternity, but this is entirely a new audience for me. Thank you very much for giving me an opportunity.
You're welcome, Doctor. And as always, we've requested Doctor to make a presentation. So those of you who are here, you can make the presentation, you can watch the presentation. And while you're watching the presentation, if you have any questions, as always, please put them in the Q&A tab. And once again, mention your age and your gender so that Dr. Limesh can give a considered response. And that's it. So he will make a 15 odd minute presentation, 10 to 15 minute presentation. And after that, we'll throw it open to questions as always. Over to you, Dr. Limesh.
Thank you, Mr. Pradyuman, sir. I was surprised when Mr. Pradyuman asked me to speak about this hyponatremia. This is basically a complex medical term which we usually ignore. Like, what is this? What is this heck about sodium? This is nothing but sodium is nothing but salt which we consume in various forms. But this has a critical role in day-to-day activities of our body, like in our memory, our actions, our mobility, our mood. Everything depends on our sodium levels. So, low sodium in medically defined terms is nothing but hyponatremia. When it's in the excess of sodium, we define it as hypernatremia. So both forms of this electrolyte imbalances have deleterious effect, bad effects on our body. So the major critical role of this sodium is by the kidneys. So we will go directly to the renal sodium handling. So we know our daily intake of sodium is somewhere around 3 to 4 grams in the US, but in Indian data, we consume around 10 to 12 grams in the form of all the preservatives, chips, name anything, everything is salt-based. Even the pickle, chapatis are made, sambar is dipped in excess salt. And if we look at the sodium handling in the kidneys, whatever the sodium is there, it is in the tune of 1.5 grams of 1.5 grams, that is 1.5 kilos of sodium is been reabsorbed in the body per day. That is, the kidney has an efficiency of 99.6% of this sodium reabsorption in the body. The kidneys plays a critically important role in the renal handling of the sodium. So most of them is absorbed in the S1 segment. This is a proximal segment in the nephron. Nephron is nothing but a functional unit of the kidney. In each kidney, we have about each 1 lakh of nephrons in both the kidneys. So these are few mechanisms how sodium is handled in the kidneys, mainly by the pressure natriuresis or a renal sympathetic activity or an enzyme called as angiotensin II or JJ apparatus and tubuloglobular feedback. These are very complex terms. I'll keep it very simple. Whenever there is excess sodium in the body, the kidney excretes all those excess sodium in the body. When there's less sodium in the body, the kidney tries to reabsorb all this sodium through the kidneys. And second important critical part of the renal sodium handling is in the loop of Henle. And again, in the loop of Henle, we have few control mechanisms in the form of sympathetic activity, cyclic AMP mediated vasopressin or procalcitonin inhibitors, or an extra calcium and increased flow through the tubules. Finally, the fine tuning of this sodium is in the distal nephrons. I'll just skip through this. So to summarize, here we have a proximal tubule. This is a nephron. This whole thing is called the nephron. This is mainly involved in the concentrating and production of the urine. In the proximal tubule, nearly 60% of the sodium is absorbed in the thick ascending loop of Henle. 30% of sodium is absorbed, and remaining 7% in the distal convoluted tubule and less than 1% in the collecting tubule. This is how the sodium is handled through the kidneys. So coming to the definition itself of hyponatremia, as we defined, sodium is a major extracellular cation, and anything less than 136, we define it as hyponatremia. And this has a prevalence of 15 to 30% in the hospitalized patient, and 2 to 3% patients may have very low sodium in the critical values of less than 125. And this low sodium is associated with increased morbidity and mortality in the hospitalized patients. So we have two types of hyponatremia. It could be a symptomatic or asymptomatic. Symptomatic means the patient may be having some symptoms of hyponatremia like drowsiness, irritability. Asymptomatic, even though the sodiums may be very low, they might not be manifesting any symptoms of sodium itself. And it could be acute hyponatremia and chronic hyponatremia. Acute means anything less than 48 hours. Chronic means more than 48 hours of low sodium in the patient. And based on the severity, it could be a mild without any symptoms or very severe where the patient might be even in coma itself. So basically, sodium hyponatremia is indicator of a low plasma osmolality, and hyponatremia without osmolality is not a very sum. It is usually a common phenomenon which we see in the post-op patients. So as discussing with you, what is this symptomatic hyponatremia? Symptomatic hyponatremia may have non-specific symptoms like myalgia, means they may having some body aches, and subtle neurocognitive symptoms like irritability. Patients may be irritable, they may be lethargic, they may be mood swings, they may be mood instabilities. They may be keeping quiet for a few minutes, then they become hyperactive. In the severe forms, they may have cerebral edema, means the whole brain is flooded with water. Whatever the brain we have, it has a limited capacity to expand the brain. When the cerebral edema is nothing but water is more getting accumulated in the brain because of this low sodium. That is one of the dreaded complication of this hyponatremia. This raised cerebral edema causes raised intracranial tension, where the patient may throw a fits, they may go into irreversible brain damage. And chronic hyponatremia may be associated with osteoporosis and increased incidence of fractures. So we define what is acute hyponatremia. That is anything hyponatremia that happens less than 48 hours, and chronic which happens more than 48 hours. And it usually picked up on a neurocognitive symptoms on careful examination. This will skip. This is how the brain adapts to a low sodium. So when there is a normal brain, it's a normal aspect. This is normal. When I'm speaking, my brain must be normal and my sodium must be normal, which I have not measured up to now. So with this normal brain, when there is low sodium in the blood, obviously this water from the blood gains an entry into the brain. Okay, and the brain starts to accommodate this excess water in the brain in the form of losing the sodium and chloride potassium, and it get accustomed to that low level of sodium itself, what we call it as chronic adaptation. And if we overcorrect this in this chronic adaptation, it may lead to dangerous and deleterious effects of overcorrection of hyponatremia in the form of osmotic demyelination. So we usually approach these patients based on the severity and how acute, how did it happen? Did it happen suddenly or a period of time? And we usually determine the cause and we see whether it's an acute or chronic hyponatremia. Second is very this one. So this is where we usually see how to approach this patient. We repeat a sodium, and if we look at the plasma osmolality, if it's in the normal plasmolality, we call it as a pseudo hyponatremia, means some other factors are causing the hyponatremia, excess cholesterols or excess protein in the body itself. And a true hyponatremia means the patient will be having a low sodium itself. And in the low sodium, we assess in the form of hypovolemia or a euvolemia or hypervolemic hyponatremia. Hypovolemia, it could be extrarenal loss, such as in diarrhea when there is patient having excess loose stools, loose motions, or patient must be having excess vomiting, or very commonly we see in burns, except more than 30% of burns will be associated with hyponatremia. And we also see a renal volume loss, such as when we use a diuretic, that's a water pill, when we use it to get rid of excess water and sodium. Or it could be a euvolemic hyponatremia in the form of SIDH, that is syndrome of inappropriate antidiuretic hormone. That is the most common cause of euvolemic hyponatremia in the form of 60 to 70%. And low thyroid status, hypothyroidism, can also be associated with hyponatremia, and adrenal insufficiency, and psychogenic polydipsia. Means psychogenic polydipsia means psychiatric patient without his knowledge is go and consuming more water without its knowledge. What will happen? The body will get diluted with more of water, and this will cause hyponatremia. Hyperolemia means the volume status of the patient itself will be more in such conditions such as heart failure, liver failure, and few conditions in the kidney failure and excess leak in the nephrotic syndromes. This we discussed, so I'm not going to do all this. So we'll just come into the treatment. It's nothing but basically we have to replace how much the sodium has been lost in the patient by this desired formulas. Sodium deficit is total body water into desired sodium minus sodium. We tend to correct this sodium very slowly. We don't aggressively correct this sodium. We correct this over days to weeks. We don't correct it overnight, like the potassium. Like for example, the potassium, you say it's 1.2, normal is 3.5 to 4.5. If we see an hypokalemia, we tend to correct that very aggressively. But when we see an hyponatremia, we tend to correct it very slowly so that the patient, as we discussed, should not develop any CNS complications. With the various forms of sodium, like we can ask them to take excess salt in the diet, or we usually correct them with sodium chloride infusions. And also we treat them with etiology-based treatment. With this, probably we'll take some questions. Any questions are there in the audience?
Absolutely. Thank you. Thank you, doctor. Doctor, can you close your screen share? There's some questions that are coming. Great. Shall we? Are you done with the presentation fully, or you want to take the questions now and then again do a presentation?
I just up to now, what is the basic sodium?
So let's do one thing. Let's look at your entire presentation, and then we'll look at the questions.
Okay. Okay, sir. Okay. So we also have few drugs which corrects the sodium, that we call it as a Vaptans. This is basically a sodium correcting drug. So it acts on the vasopressin. This vasopressin was in 2012. We got, the Nobel Prize was got for this molecule, for this very important discovery in science, that is vasopressin. It's a protein which regulates the sodium in the distal tubule, where this vasopressin causes the water movement from across the basolateral membrane in the renal tubules. And this vasopressin inhibitors, such as vaptins, has come out to be the major game player or game changer in the treatment of hyponatremia. Well, we have few vaptins such as tolvaptan and conivaptan. This tolvaptan is a selective vasopressin blockade in the distal convoluted tubule, and it is given in the dose of 15 milligram per day. And we usually don't excrete more than 60 milligram per day. And the second drug is a conivaptan. It's a combined vasopressin 1 and vasopressin 2 blocker. It has IV and bolus infusions. This is one of the complication of overcorrection of this sodium. It causes this is MRI of the brain. This is the pons. This is in the midbrain. This is below. It's at the level of the neck. When we overcorrect that, this what are the pons? I was talking to you. There's water accumulation in the brain. These pons, they swell up, and whatever the connections that come from the brain to the spine, it is cut off. So patient will be some sort of spastic paraplegia, or they'll go for coma, or they'll develop complications. This is why this happens, because of the too fast correction of chronic hyponatremia. I mean, I was talking to you, the patient may be not having any symptoms, but if someone sees their sodium to be 122 or 123, they start correcting that, ringing the panic button, and the fast to correction causes this central pontinomyelinolysis. Sure. Thank you, sir. I'll be happy to take any questions now.
Thank you very much. I'm glad. I think it was a very good and detailed presentation on an issue like this, where Doctor, quite a few questions have come in, but I've got at least 4 questions which are similar. Yeah?
Yes, sir.
1 over here and 3 via SMS. Doctor, what is the normal intake of water for a person above the age of 60? And the second question, and this has been specifically asked by Mr. Anil Kumar Chopra, who's 73. Do we take RO water or normal water?
Okay, sir. So it is like this. So the normal, a man consumes around 1.5 to 2.5 liters per day, depending upon his availability to the water intake itself. So the minimum water where a man can live is around 500 ml water. So I can live per day with only 500 ml of water. That's the minimum water I need to excrete all my waste solutes through the urine. And the maximum water which I can consume is around 4.5 to 5 liters, more than which my body will not take that.
So water would mean in various forms, right? Not just,
in various forms.
Not just plain water, but it could be a soft drink, it could be some buttermilk.
Tea, coffee, sambar, rasam, whatever, sir.
All liquids.
All liquids. That's the minimum. 500 ml is minimum for me to live, to excrete all my waste substance to the urine.
Right.
So only 2 conditions where we ask the patients to take more water is if they have stones, if they have kidney stones, and they have recurrent urinary tract infection.
All right.
Only in these 2 conditions, we ask them to drink, say, somewhere around 4 to 5 liters of water, where they have to produce somewhere around 3 to 3.5 liters of urine, so that they flush out the bacteria and the stones from their urinary system.
All right.
Or we commonly ask the patient to consume water according to their thirst. If I feel thirst, I'll go and drink in water. That should be sufficient for us, sir.
Okay, all right. Great. Thank you. Uh, and another very basic question is, what kind of salt should we take? Uh, you have a low, and this is asked by Shobha Srivastav, but I'll just add over there that, you have iodized salt, you have plain salt, you have some kind of pink salt which is available, you have, what is called rock salt, etc. So what is the ideal salt that one must consume?
So why the iodized salt? Why Government of India wanted iodized salt in our diet was to eradicate goiters, means hypothyroidism. So the Government of India started iodizing the salt in all the various forms of salt, so that the thyroid issues has to be excreted with the grassroots level itself.
Right.
So recommendations are to go ahead with the iodized salt, except in cases of hyperthyroidism, where we ask them to restrict their iodized salt. Apart from that, all salts are the same, sodium chloride. Either it's a rock salt, it's a black salt, it's a green salt, whatever the salt, it's basically the same. Or it's only the preparation, how they make it, each company, how they make it, but the content is the same, sodium chloride only, sir. And the normal, which we recommend, WHO, World Health Organization recommends, is somewhere around 2 grams of sodium chloride. 2 grams of sodium, that corresponds to 4 grams of sodium chloride. That is 1 teaspoon of salt. Sorry, 1 tablespoon of salt. 1 teaspoon is 3 grams, 1 tablespoon is 5 grams.
Right. All right. Yeah, great. Thank you, doctor. This is, I think, as clear as one could get, because there are so many types of salt that are available now.
Yes, sir. It's all company based. So basically, any Tata salt is enough for us, but it should be in the limit. So if they have some cardiac issue, if they have some renal issue, we ask them to cut down their salt to 2 to 3 grams per day. And believe me, patients will not follow that. It's very, we Indians are used to more salt in our diet. We want everything to be spicy, everything to be salty. If we try, if you try, if I try without salt, even I also can't eat that food. So.
Right, absolutely. Doctor, we have a question from Mr. Brijendra Kumar, who's 78. And his question is that I take diclofenac-based painkiller for my knee and joint pains. I do give a break of about 1 week. What is the risk to the kidney? I know it's not exactly a question which concerns
That's
us.
fine. I think Mr. Brijendra Kumar has asked an excellent question. This diclofenac or painkiller abuse is rampant in India. Sorry to say, because our people, our Indians, without any knowledge, they go to the pharmacist, they ask some painkillers, they give diclofenac. The patient will come, he'll come and take the painkillers. We call this as NSAID abuse, means over-the-counter abuse. Without their knowing their side effects, people tend to take these painkillers, sir. These painkillers, if it is taken over years together, that will cause their kidney functions to go down. That will cause hypertension, water retention, prostaglandin inhibition. They develop some sort of chronic kidney problem, and indirectly it affects the heart.
Right.
So we, in such cases, we recommend non-steroidal, and apart from NSAIDs, that the painkillers, we have kidney safe painkillers such as paracetamol, codeine, or Ultracet. These are kidney safe. They can try that instead of taking a long-term diclofenac. Well, this NSAID abuse, this painkiller abuse, this has been going on for a long time. We have been talking to the IMAs, but nothing has happened till now to stop that over the counter without doctor's prescription. Why should a pharmacist give himself?
The doctor, over consumption of paracetamol could be bad for the liver, right?
It should be in the grams. It should be in kilos. Like he has taken hundreds of kilos. That's the where the kidneys get affected, and it's usually in the children. Adults, we usually don't see this paracetamol poisoning, sir.
Doctor, can I, on a lighter note, can I just ask you to guess how many kilos of paracetamol does an Indian adult have?
I mean, it is there, sir. I mean, like if we go to the urban situation and in the rural population, probably rural population is consuming less paracetamol compared to the urbans because we are more easily accessible to the medical shops. Every nook and corner, you're having a medical shop. If we go and ask, give some Dolo, they give it off. So it should be somewhere around 5 to 10 kilos over a year, a urban Indian consumes compared to 3 to 4 kilos for a year in a rural population.
Doctor, we have a question from Mr. Satish Kalia, who's 78, had UTI progressed to CKD in 2018. His creatinine went up to 6 and now it's at 1.3. His question, doctor, is what is the relevance of checking sodium or potassium in CKD KFT cases?
Okay, sir. I think the why this patient has developed a chronic, I mean, why sir has developed chronic probably because of urine infection. We tend to monitor sodium and potassium along with urea creatinine because in kidney patients, the potassium will tend to go up. They'll have dangerous high potassiums, which may lead to cardiac arrest. Anything above 7 is certainly dangerous for us. The heart will stop beating. And in elderly, the sodium will be tend to be low. So what we call it as hyponatremia without their symptoms, they'll be having, as I told you, asymptomatic hyponatremias. So in elderly population, we tend to see low sodium and high potassiums, which is in either ways is very detrimental for us.
Right. Thank you, doctor. Doctor, we have a question from Mr. Satish Kalia again. His second question, and I would ask, how often should we go in for KFT in case of CKD?
Sir, if you are in advanced stage of kidney problem, when your GFR is less than 30 ml, we recommend once in a month. If your GFR is somewhere on 30 to 60 ml per minute, once in 3 months, and is more than 60 ml per minute, we recommend once in 6 months. And we ask you to monitor your blood pressure at home regularly, and we want you to consume the pills on daily basis.
Thank you. We have a question from Mr. Suresh Wangankar. He's not mentioned his age, but his question is, for maintaining sodium level, I have been advised Natrize 15 mg or Tolvat 15, Tolvopatin.
Tolvapatin, yes, sir.
I don't know, he has not asked a question, but his, I guess he just is asking whether he's having the right medicine or is there anything else to have.
I mean,
before doctor responds, many of these drug-related queries that you have, while this session is, we have a doctor in the house and he's taking all these questions, but do remember, whenever you have a specific problem, there's nothing better than meeting a doctor directly or interacting with one. You can always get in touch with Dr. Limesh over and do a teleconsult if you like, but always good to get do a clinical examination and speak to a doctor for your specific query. These sessions like these can only be very general, can of course respond to specific questions, but still always recommended that that you respond to questions. Yeah, sorry, doctor.
No worries, sir. I mean, what you told was absolutely correct. Without examination, probably we may miss a lot of things. Their blood pressures, their any leg swelling, how are they feeling? So one-to-one meeting with a patient.
So Mr. Suresh Wangankar has his question is, he's 74, and his question is, for maintaining sodium level, I have been advised Natrize 15 mg or Tolvat 15, and I guess this question is it the right?
I think sir must be having some long-standing hyponatremias. So probably they will use that Tolvaptan for a long time, or sir must be having some water accumulation somewhere in his body. So in these two conditions, I think Natrize has been advised in them, sir.
Thank you. We have a question from Mr. Dinesh Mohan Verma. He's 74. He's a heart patient and his sodium is 130. He is requesting for some advice.
So the best way to deal here with is the salt restriction, sir, because sir, what he has developed hyponatremia is because of excess water in his body. It is like this: if you put 1 kilo of salt in 1 liter of water, and if you put 1 kilo of salt in 10 liters of water, so obviously the 10 liters of water with 1 kilo of salt will have low sodium. So the best thing to do is water restriction. If you, from 10 liters, if you bring down to 1 liter, your sodium will automatically go up.
Right. The same question is from Akori Kumar, who also has a 130 thing. Doctor, a question from Meenakshi Chokshi. For hypothyroid, salt intake and which companies, how can we reduce hypothyroid?
Okay, sir. It is like this. So the causes for hypothyroidism will be numerous. They may have some autoimmune disorder. They may have some enzyme deficiencies. They may have nutritional deficiencies. Each has to be looked at in a separate way. And along with iodized salt, where we recommend around 3 to 4 grams or max 8 grams per day, they also have to go for the thyroid supplements. Then only the hypothyroid will be corrected. Not alone the iodized salt or the thyroxine intake, it is also the iodine intake which matters. So both has to be in the equal amounts to correct their hypothyroidism.
Doctor, I know you have answered this question, but I'll just take it anyway. This is from Shamla Ravi, who says, for hyponatremia, is there a home remedy before seeing a doctor in an emergency?
No, sir. I think hyponatremia is an acute medical emergency. You have to meet the doctor.
Absolutely. I think it's as crystal clear as that. We have a question from Mr. Sunil Maru, who's 63. He's given a host of medicines that he's having, but I want to avoid that. He says, my sodium for the last few years has been around 130, and he consumes about 3 to 4 liters of liquid per day. And he's taking quite a few medications for his heart problem. His question is my sodium level due to my excess liquid intake or due to the medication? He's taking Prolomet XL, Cardex, Ismo, Nicorin, Aspirin, Topivas, Rosovas.
Is this Prolomet XL 25 mg plus 12.5 mg only Prolomet or any thiazides is it taking, sir? I mean, like any hydrochlorothiazide, chlorothalidol.
He's responded to that. But whatever it is, what do you think is?
I think none of the medications are causing that. Probably sir must be consuming more water here. So probably sir has to cut down on his water intake.
Right. Doctor, we have a question from Katie Daganchi, who's 72. And her question is that in the blood reports show 10 to 15 HPF pus cells in the urine. How much water should I take to watch out the pus cells, or should I take some medication for the same? And what are the reasons for pus cell formation?
Sir, it is like this. So probably madam must be having asymptomatic bacteriuria. Means she doesn't have any symptoms, but still she must be harboring some bacteria in her urinary passage. So probably best thing to meet her doctor and get a urine culture done and ultrasound done for further evaluation.
Thank you. We have a question from Deepak Vasan, who says, how do you treat a patient who develops hyponatremia due to salt-restricted diet because of hypertension and can't be put on low water intake due to certain urological issues?
Sir, sodium restriction in a normal person with normal kidney functions will not cause hyponatremia in any case, because kidneys are such that whatever salt, if it's a high salt or if it's a low salt, the kidneys have the perfect ability to maintain the sodium in the normal levels. If the kidney functions are affected, then only some sort of, or if cardiac functions are down or thyroid issues are there, in those situations only you will see hyponatremia. If the kidneys are normal, in no way the patient will develop hyponatremia.
Thank you.
And salt restriction in a normal person will not cause hyponatremia in any way. That's the system God has given us.
Great. Doctor, we have a question from Kashi Vishwanathan, who's 75. And his question is, I suffered acute gastroenteritis and severe dehydration last month. Now I have recovered and it's normal. Urologist found that I have several storage LUTS. Uroflow is low. Prescribable Silodel 8, 1 per day. Next follow-up after 6 months. Can you explain my conditions in simpler language?
I think Mr. Kashi must be having the bladder dysfunction itself. The bladder must not be contracting enough to outflow of the urine. So they have given this Silodol so that the bladder wall will be contracting and will be voiding. The urine will be voided in a perfect manner, sir. I think that's the simpler way to put in that case.
Doctor, there's a question from Usha Jacob who says, salads we eat mostly without salt. Does lowering salt consumption too have negative impact?
I don't think so, sir. So, I mean, you get your salt in either ways, like you're in dosas, in your idlis, in your sambas, you get your salt. The body will preserve those excess salt in your body, and restricting the salt in the salads in no way is going to affect in your day-to-day activities. And in fact, it is good for lowering your blood pressure. If you restrict your salt, yes, your blood pressure is well controlled.
Thank you, Doctor. We have an anonymous attendee who asks, and I guess these are linked to sodium and nephrological issues. What pathology test should one do after 70 years of age?
So they're regular, sir. They should get their sugars. Sugars is the main thing, and their hemoglobin, and their liver function test, and their urea creatine electrolytes with a urine routine, and then ECG echo. That covers everything along with a chest X-ray.
Right. Doctor, this Mr. Vijendra Kumar, he's asked a question. I'm not going to name the company that he's put over there, but he says there's a company which produces rock salt, selling at over 100 rupees per kilo. And they also produce iodized salt at rupees 20 per kilo. There has to be some difference in the two salts. Request your comments again. This is a big confusion about salts, which one to have. I guess a lot of advertising has happened. And
yes, sir. I completely agree with you. Probably, I mean, we should ask the company guys why, I mean, the Tata guys, why they have been so much of this one. But our recommendation is normal iodized salt. That's all, sir. Nothing else.
Normal iodized salt is what it is. Doctor, we have two more questions, and I know these are. One question is, if somebody wants to contact you, how does one do that?
Sir, we have that NH Care app. I'm available on that, so they can fix my appointment and they can meet me.
Meenakshi Chokshi ji, unfortunately, I'm not going to be able to share Dr. Limesh's mobile number, but you can contact him via the NH Care app, which is a very robust and good app, and you can get across to Dr. Limesh on that. Doctor, there's a question. There's somebody who's 71, and Madhusudan Bhandarkar. I don't know whether he has got anything to do with Madhur Bhandarkar, who's a filmmaker, but he says perhaps you should, with all your good looks, you should act in Bollywood movies. But why Bollywood? You have bustling film industry in Karnataka. So why come all the way here?
Thank you, sir.
Last question, which is there. Shamala Ravi asks, what is a band-aid solution to normalize fluctuating sugar for a surgery if nothing works?
I really don't know, sir.
Yeah, this is a tough question, and I don't think there can be a ready response for this. Doctor, we are so thankful that you are here.
Thank you, sir.
And you have answered, as I can see, that 27 questions you've answered already today in the short span of 40 minutes, and an excellent presentation that you made.
Thank you, sir.
Thank you very much. Thank you very much for your time on a Saturday evening, and thank you to all of you who are here today, who have attended, and to the team at Nayana Health. Thank you for facilitating this, and we'll be back once again next Saturday that is the 15th of July, 2023. And you can pre-register for our health webinar, which you know. Many of you have already pre-registered, but those of you who haven't, the pre-registration link is there on the website, which has been put on the chat window right now. And you can pre-register so that you get alerts about our webinars as soon as we have confirmed the doctor. And next Saturday, remember, is July 15th. It's also the day for our 4th anniversary issue of Seniors Today. What I'm going to do is I'm going to request my producer to put in the chat for the last 48 issues of the magazine. You can access the last 48 issues of the magazine. It's all free of cost. As you know, Seniors Today is a free of cost offering, and you can go there, register, and also participate in all our events which happen through the day. Health webinar, of course, is our oldest event, which has been happening for the last 3 years, and there are quite a few events that happen through the week. And thank you once again, Dr. Limesh, for being here. It was a very good presentation, a detailed presentation, and you answered all the questions. Thank you once again to all of you for being here. Thank you.
Thank you, sir. Thank you very much.
Subscribe now and press the bell icon. Never miss an update.